Dear colleagues, we can see this is a cataract with pseudoexfoliation. Nuclear sclerosis is about grade 3. We can see the pseudoexfoliation material at the margin of the dilated pupil. I have taken up this case for surgery. Let us watch the surgical steps. By this time, all the incisions have been made. Now, I want to stain the anterior capsule with trypan blue dye underneath this air bubble. And here goes the trypan blue dye. Now the dye is washed out, but before that I am injecting some adrenaline to see if the pupil dilates little more. And yes, it has dilated little more. And this will help me in doing capsulorhexis. Now, viscoelastic substance is injected into the anterior chamber. This is HPMC, that is hydroxypropyl methyl cellulose. And now a 26 gauge bent needle is being introduced through the right side port. I incise the capsule, raise this huge big capsular tag, hold this tag with utrata, go along the border of the pupil because in this case the pupil is mid-dilated, and I perform this round rhexis. Since the pupil dilated a bit, after administering adrenaline, this rhexis has become quite adequate. And now I have to do hydrodissection. So the hydrodissection is done, the nucleus is depressed, and you can see that the nucleus is rotating freely. And now visco is again injected, and now is the time to go into the eye with the tip of the Phaco handpiece, and in this case the machine being used is Oatley Cataract 3 Phaco machine from Switzerland. Very nice machine, very good hold on the nucleus for chopping. I think this is the best machine for holding the nucleus. It has got a very firm hold. No financial interest, but very happy with this machine. Now see, as I apply vacuum to hold the nucleus, the pupil is getting small. However, since the cataract is not hard, I am sure I'll be able to manage this case without using any pupil dilating device. Here I am holding the nucleus at several areas and chopping it. And this is a fragment, free fragment. It is being emulsified and removed. This is another free nuclear fragment. It is also being emulsified and removed. Ultrasonic energy used in this case is 65%. Flow rate was 45 ml per minute, and vacuum set was 450 millimeter of mercury. This is the last few portions of the nucleus. And see, I have removed the chopper so that the anterior chamber becomes more stable. And see the followability. All the pieces just come to the tip. And now, after injecting some viscoelastic substance, that is HPMC, I am going to remove the cortical matter that we can see. And see how easily the cortical matter can be removed with this Simcoe cannula. And in my hand it is faster than bimanual IA. That's it. Very nicely, the cortical matter is coming out. Now, little bit of cortex is there at around 12 o'clock. It is being removed. That's it. All the cortical matter has been removed nicely. You can see a lot of air bubbles in the anterior chamber sticking to the corneal endothelium. So how to remove that? Let us see. I inject viscoelastic substance and all the air bubbles come out. And now, since the pupil has become small by this time, I want to enlarge the main incision by about 0.2 millimeter, so that the main wound is having a width of 3 millimeter at this time. Now I go into the anterior chamber and inject the IOL in such a way that the leading haptic goes into the bag. In wound-assisted delivery, it may not be possible, but if we enlarge the wound and go into the antechamber, then we can direct the lens in such a way that the leading haptic will go definitely into the equatorial region of the capsular bag. Now here, after implanting the trailing haptic into the capsular bag, the iris is retracted and it is seen whether the lens is in the capsular bag all around or not. Now, viscoelastic substance is being removed thoroughly, first by Simcoe cannula. I irrigate for some time and then aspirate with the Simcoe cannula. And now this is a thorough cleaning of viscoelastic substance. Actually, I take a lot of time to remove visco, and I wish I could avoid visco during implantation of intraocular lens in all cases, but it doesn't become possible. Now I irrigate with the irrigating probe of bimanual IA all around. Irrigation and aspiration together. You can see some bleeding at the main wound, and that is good. This wound will heal faster, and there will be stronger adhesion between the anterior and posterior lip. Now the side ports are hydrated, and the case will be concluded after this final lavage with BSS, that is balanced salt solution. That's it. The wound integrity is checked and the case is concluded. Hope this video will help you in your practice.